Good afternoon. My sincere thanks to the organizing team for giving me this wonderful opportunity to be among with you. My topic for discussion will be on management of heart blocks in ST elevation myocardial infarction. So we all know that bradyarrhythmias and conduction defects are relatively common after an acute coronary syndrome. They are both result of an autonomic stimulation, and they can also be part of ischemia and necrosis of the conduction system. So the most important question when the patient develops a conduction system issue is, do this patient needs a pacing? Two major factors determine the need for cardiac pacing: symptoms associated with the bradyarrhythmia and the site of conduction abnormality. So in the setting of acute coronary syndrome, we can see different kind of conduction issues happening. One could be abnormalities of sinus impulse formation or conduction, problem from the sinus node, disorders of AV nodal conduction, and disorders of intraventricular conduction. In general, any patient with bradyarrhythmia that is symptomatic or hemodynamic compromise has to be treated aggressively. If you look at sinus nodal abnormalities, patient can have sinus bradycardia, particularly patients with inferior wall myocardial infarctions, sinus arrest, sinoatrial exit blocks. The incidence varies from 5 to 30%. Abnormalities and sinus rhythm are more common with infraposterior wall infarcts because the same artery supplies sinus node, and they can also be mediated by vagal related activities. The treatment is mostly not necessary unless patient is symptomatic. Atropine is highly useful. Sometimes if the patient has an associated hypotension, beta-1 agonists like adrenaline or noradrenaline can also be tried upon. If the bradycardia is prolonged and severe and is not responsive to atropine, some patient very rarely may require a temporary pacemaker. Disorders of AV conduction, which we are worried more, occurs in around 12 to 25% of the patients with acute coronary syndrome. First degree AV block happens in around 2 to 12%, second degree AV block in around 3 to 10%, and complete AV block in around 3 to 7% of the patient. The majority of patients have an evidence of infraposterior wall infarction. Approximately 70% of the patients have an infraposterior wall MI because of AV nodal artery arising from the dominant RCA, and also activation of cardiac reflexes with augmentation of parasympathetic vagal tone, and also release of adenosine caused by inferior ischemia or infarction. These are the common reason why patients with infraposterior wall infarct develops AV blocks more often. So whenever you see a AV block, the one thing we are worried is, one is symptom, second is there is any chance of progression. The first degree to third degree AV block, the progression of first degree AV block to high grade AV block varies from 10 to 30%. From second degree AV block to complete AV block is around 35%. The development of high grade AV block in the setting of infraposterior wall infarct is usually associated with an narrow QRS because a lot of times you see problem happening at the AV nodal level or vagally mediated. The junctional escape rhythm usually remains reasonably stable. You will see a heart rate of around 50 to 60 beats per minute, and this can be increased by intravenous atropine. We know very well that most of the blocks which happen at the infraposterior wall infarct are at the supraisian level, so they may respond to drugs. A lot of patients with infraposterior wall MI, even with a complete heart block with a reasonably stable escape rhythm, may not need a temporary pacemaker. So the typical inferior wall MI presenting with a complete AV block. So when the patient is an AV block, when patient has a first degree AV block with a narrow QRS, it is usually related to a AV nodal issue, what we call as a supraisian AV blocks. You may not require, and we hardly put a temporary pacemaker for this location. Type 1 secondary AV block with wide QRS complex sometimes may represent a block at the lower level. It could be a Hessian or infrahessian AV block. And this, particularly in the setting of anterior wall MI, temporary prophylactic pacemaker may be required if the patient has a persistent AV block, particularly with a wide QRS escape. The patients who have a type 2 secondary AV block and wide QRS in the setting of inferior wall infarction or during anterior wall MI, a temporary pacemaker may be required if the patient has a wider QRS. The patients with type 2 AV block with narrow QRS, particularly in the setting of inferior infarction, they rarely progress to high-grade AV blocks, so they don't require anything to do, just watch them. When you have a high-grade AV block in patients with anterior myocardial infarction, this becomes a complicated issue because high-grade AV block complicating anterior limb usually is an infra-ACIN AV block. In general, interruption of blood supply to anterior intraventricular septum that is severe enough to cause AV block usually causes severe LV dysfunction because the patient would have lost good amount of myocardium when the patient develops an AV block. This patient may require a temporary pacemaker if there is a persistent complete heart block even after revascularization. So this is a typical complete heart block arising from an anterior wall MI. The patient has an anterior wall ST elevation along with complete heart block. The disorders of intraventricular conduction system issues in acute coronary syndrome. The development of new bundle branch block can happen in around 5 to 15% of the patient who have an acute coronary syndrome. New bundle branch block is relatively more common, around 3 times more common during anterior wall myocardial infarction than during an inferior wall myocardial infarction. Acute myocardial infarction with any amount of bundle branch block pattern increases the mortality both in and out of hospital. Is there any chance that bundle branch block can progress to a complete heart block? If patient has an acute MI and bundle branch block, there's a 4 to 5-fold increase risk of progression to high-grade AV block. It's around 4 to 18%. So if you look at the patient group and the risk of high-grade AV block, the first degree AV block and new bifascicular bundle branch block, the risk of developing a high-grade AV block is pretty high, around 38 to 43%. A first degree AV block in a patient already have an old bifascicular block, it varies from 20 to 50%. A new bifascicular bundle branch block at the range of 15 to 30%. And if a patient develops an alternative bundle branch block, it's pretty high, close to 50% of the patient, 44% of the patient can develop a high-grade AV block. When you will put a temporary pacemaker in patients who have an acute myocardial infarction, the class 1 indication remains asystole. And when the patient has a symptomatic bradycardia, this could be even a sinus bradycardia, which causes symptoms like hypotension and signs of hypoperfusion, or type 1 secondary AV block with hypotension, which is not responding to atropine or beta-1 agonist. A patient who has a bilateral bundle branch block, that is alternating bundle branch block, when the patient has an alternating between right bundle and left bundle, or a left bundle, right bundle with a left anterior or left posterior fascicular blocks, you may require a temporary pacemaker if it happens after you have done a revascularization. New or indeterminate age bifascicular block, the first degree AV block also will require. Class 2 indications remain. Sometimes you may have to put on incessant VT for some time overdrive, and recurrent sinus pauses not responsive to atropine also may require. Otherwise, bifascicular blocks may require. So when you have a fascicular blocks of indeterminate age or new or age indeterminate isolated right bundle blocks, they usually don't require any TPA most of the time. You don't put a TPA if a patient has a first degree AV block or a type 1 second degree AV block with normal hemodynamics, the patient who has an accelerated ventricular rhythm, or a fascicular block or bundle branch block exists before itself. The indication to permanent pacemaker in a acute coronary syndrome situation is limited, and the decision has to be made with a lot of consideration because permanent pacemaker is a lifelong commitment for the patient, and patient with complete heart block in a ACS could be a young patient, may require multiple generator changes, and there could be revision secondary to malfunctions of the lead or pacemaker. So this is particularly important when you are considering a young patient. So the problem with acute MI complete heart block is there are a lot of thinking process has to be put in before taking a patient for a permanent pacemaker. So if you see a sinus node dysfunction in an acute MI, it is relatively benign and permanent pacemaker is rarely required. You hardly put a permanent pacemaker for a sinus node dysfunction because it recovers well and responds to drugs. Second degree, even third degree AV block after inferior MI is usually reversible and rarely requires a permanent pacemaker implantation. However, conduction defects after an anterior wall MI are usually require a permanent pacemaker implantation or ICD if you think that the revascularization was delayed and patient may develop a pump dysfunction at a later date. So the patients with anterior MI and AV block, primarily the AV block is secondary to the extent of myocardial injury. So these patients have a poor prognosis compared to the patient who has not developed a conduction system disease. If a patient with an AV block in an acute myocardial infarction and his ejection fraction is less than 35%, and you have a situation where he is going to pace 100% with a pacemaker, then you can consider a CRTD. If you have done a revasculation, which you feel like as a delayed revasculation, and you don't think that there is a possibility of recovering LV dysfunction is not there, or you see a patient late after a myocardial infarction and patient presents with a non-viable area, then you know very well this patient is not going to improve upon. So these patients, you can consider CRTD thinking on an individual basis. So the class 1 recommendations remains persistent second-degree AV block and with his Purkinje system involvement with an alternative bundle branch block, or third-degree AV block within or below his Purkinje system after ST elevation myocardial infarction. Any patient who has an infra-ACN AV block secondary to myocardial infarction may require a pacemaker. This can be assessed by surface ECG by looking at the QRS width. The wider QRS, the higher chances that block is infra-ACN. If the patient, you feel a patient has a infra-ACN block, but you're not very sure about it, it's very easy to confirm it. You can just put a catheter at the his bundle level and see which part of the conduction system is involved. A short, small EP study can sort out the problem for you. If the patient has a prolonged HV interval or a problem related to the infra-ACN level, you can just put a pacemaker in this patient because this may not recover. Any patient who has a persistent symptomatic second or third degree AV block will require a pacemaker. Where you don't put a pacemaker. Permanent pacemaker is not indicated with the transient AV blocks in the absence of any intraventricular defects. Transient AV blocks in the presence of an isolated left anterior fascicular block. New bundle branch block or fascicular block in the absence of an AV block. Persistent asymptomatic first degree AV block in the presence of even any bundle branch or fascicular blocks. So with this, I'll close my talk. If there are any questions, I'll be happy to answer. Thank you.